Everything's Cleaner in Texas, the show where we spotlight the people, processes, and products that are helping Texas clean freaks fight dirty better. From hospital sterilization teams to cutting-edge technology, from deep cleaning secrets to industry game changers, if it's making Texas fight dirty, we're going to talk about it on this show. My name's Hank Balch, alongside Dusty Glass, and every episode we'll be diving deep with the experts, innovators, and frontline fighters who are setting the gold standard for cleanliness across the Lone Star State. Because in Texas, we don't just fight dirty, we do it big. So grab your boots, buckle up, it's time to get clean.
All right, all you clean freaks out there, we are coming to you live here. We've got a really special guest for you today. Really excited to bring Miss Amy to you from STERIS. And Miss Amy, what are we going to be talking about today?
Yeah, so thanks for having me. Today we're going to talk about biofilm. Lots of different things all about it.
Awesome. That sounds amazing. We're in the midst of this 12-part podcast with HSPPA, the local Houston chapter here. And we're really excited to have our partners at STERIS with us. So can you kind of describe to me here, what is biofilm?
Yeah, so biofilm is wicked. It's a really nasty kind of thing, and it's, in my opinion, kind of fascinating as well. It is a substance. It is a type of contaminant, if you will, that kind of forms on the surfaces of our instruments and our devices, surgical things that we use every day for patient care. And it grows and it collects microbes, and it can be disease causing. It can really lead to some bad infections. And, we don't like it. We want to get rid of it or keep it from forming altogether. So I love talking about it. I think it's very important from a clinical perspective that we understand what it is and how to deal with it, because it can really impact our patients, and it can impact our work on a daily basis.
Awesome. And so, like, how it's a curious thing, biofilm here, how did you, can you kind of tell us a little bit about you and your story, and how does this, how did you become the biofilm queen here?
Well, I'm an educator at heart. I've been doing it for well over 26 years. And I've also, worked in the perioperative world for about that long as well. And when I came into my education role, these were just one of the things that I started to learn about, how to take good care of our instrumentation. And obviously, as a nurse, it's all about patient care. It's preventing infections. So coming into my education role with STERIS, this was just one of the topics that was very prevalent. And I feel like it is a common thread throughout everything we do in sterile processing, from the time an instrument is used on a patient all the way through reprocessing back to the time goes back for patient care. So biofilm can be present in any point in that process. What we do daily in the room, in sterile processing, even sometimes when we put something into storage, is going to impact whether or not biofilm starts to form. So I don't know that I can say I'm the guru on it. I've just taught a lot on it. And I think it's fascinating from a science perspective and very, very important from a clinical perspective.
Yeah. So, I'm a simple man, and if you haven't heard my backstory, I'm a simple man from Kentucky. I've been born and bred in Kentucky, and I've just been able to join the great state of Texas here in the past 2 years or so. And we're talking about, how everything is cleaner in Texas, and how, we do everything bigger here in Texas. Could you kind of break it down for us, kind of simple technicians, or, these folks that maybe they're just getting into sterile processing, and, let's say they've just got certified and they're really trying to figure out, well, biofilm. What about bioburden? I hear this hot term all the time, bioburden here. What's the difference, Amy?
Yeah, so that's actually a great question. And before we can talk about biofilm, we actually do need to talk about bioburden. Bioburden is just the basic stuff that comes from exposure of an instrument or a device to a patient. So it's the blood, the tissue, the body fluids that contaminate our instruments, devices every day during patient use. Now, the thing about bioburden is because it comes in contact with the patient, it's got microbes in it. So it's contaminated, right? And the dirtier something is, whether it's, a pair of scissors or something, laparoscopic instrumentation, something complex, the dirtier it is, the more likely there are microbes going to be present on it, and the higher number of microbes are going to be present on it. So the dirtier an instrument is, the dirtier an item is, the more contaminated it is. And we kind of measure that by a term called viral load or microbial load. The higher the microbial load, the greater the risk that that device can cross-contaminate and, lead to patient illness, patient infection. So, bioburden, it could be anything. Again, blood, tissue, body fluids, from the gut, even inside the mouth, inside the head, can be a lot of different types of things. But the commonality is it's all got microbes in it. So it can be disease causing. And what's super scary about that is that it's all invisible. You can't see germs. You can't see those microbes. They're there and we may not even realize it.
So this is kind of like when they're talking about this hand hygiene, right? Where it's so important to wash afterwards and to sanitize every time you go in and out, right? Because we can't see those things all the time, right, Amy?
Exactly. That is exactly right. Now, we may not necessarily grow biofilm on our hands, although biofilm, it differs a little bit from that bioburden because biofilm it's got those microbes. It's made up of those microbial cells. But biofilm is actually encased in a substance called EPS, which stands for extracellular polymeric secretions. Fancy science term, right? Like, I don't get into all that sciencey stuff necessarily, but EPS is what makes the difference. EPS surrounds all of the microbes and it protects them, creates this shield, and it just allows them to grow and proliferate. So while biofilm can grow anywhere, it really doesn't matter. It likes anything, any surface, living, non-living, doesn't really matter. Washing our hands, to your point, is so important because if we're contaminated, or we've got anything on our hands or under our fingernails, over time it will start to grow. Washing those hands, that friction, that's the best way to kind of get rid of all that stuff and prevent that process from starting.
Yeah. So I guess I'm trying to think from my normal technician brain here, and this is kind of why a lot of managers preach, when you go to your station, it is so important to wipe down your station, right? And get that disinfection wipe everything down, clear all your stations so that you're starting fresh, that when you assemble those trays, you're not already contaminating that with that viral load like you were discussing earlier, right?
That's right. Yeah, because, if you've got residual bioburden, let's say that you've got a tray or you've got a station, even sometimes something simple like a keyboard or our mouse even, and we don't clean it, those microbes live there, they can grow and multiply, and then that biofilm structure starts to form. We leave, we go home, the microbes don't go anywhere. They just sit and they continue to grow. So yeah, you come back the next day, you don't wipe things down necessarily, you're just ready to get started, got a lot to do. Man, as soon as you touch that keyboard or you touch that mouse or that instrument or whatever, it's going to go from that instrument to your hands, gloves, then you're going to touch something different. You're just going to start spreading it around. Again, it's all microscopic. So we don't even realize what we're doing, and then spreading the love is what I like to say. It's probably not the best terminology, but yeah, hand washing. It really is the most simple way to combat germs and infections. And when it comes to like sterile processing and our instrumentation, yeah, You need a clean slate every day. Let's wipe everything down, make sure that all of our brushes are clean, all of our surfaces are clean. Just it's best practice. It's all about following those best practices for cleaning and hygiene, I guess.
Yeah, that's so awesome. It's kind of crazy to me. I think about things that we always think in everything in an 8 hour kind of mentality. You're hearing your 8 hours, and a lot of technicians don't realize that these microbes, they don't incur overtime. They're working 24/7, 7 days a week, and they're in it to cause as much chaos as possible, right?
That's right. That's right. And, all the microbes are different. And, there's some that are slow growing and there's some that are, they'll multiply very, very quickly. And, I always use an example of like Pseudomonas. We see Pseudomonas a lot with our respiratory patients. And I know from like a sterile processing perspective, you may not know what instruments are used in what procedures. But when we talk about, respiratory or bronchoscopies and things like that, if a bronchoscope is contaminated with Pseudomonas, Pseudomonas can double or even triple 20 to 30 minutes. The bacterial load can triple so quickly because it's a very fast growing type of microbe. So, man, in just a very short period of time, we can have exponential multiplication of those microbes. And again, the higher the microbial load, the greater the risk of cross-contamination and patient infection. So if we don't get to something quickly, I bring it down and it sits for a little while, man, all those microbes are really going to start to grow and proliferate.
Wow. So what I just heard was that when let's just say I'm the technician and I look at that clock and I'm like, man, it's 12 o'clock and it's time for my lunch. You're saying within that 30 minutes that microbial load, and let's say there is a possible contamination. Let's say my technician, my coworker in the back, maybe they missed something, maybe that something happened, maybe they were rushed for a turnover, whatever the case may be. You're saying that within that lunch break that I'm like, hey, you know what? It's 12 o'clock. It's time for me to hit lunch. I'll do this tray right afterwards. You're saying within 30 minutes, it's possible to triple or quadruple these microbes in that time period?
Yeah, it depends on what the microbes are, because like I said, there's all different kinds of bacteria. There's different types of viruses and fungus and things that are out there. Some of them are slow growing and some of them are really fast growing. So it really depends on what microbe is present. Unfortunately, we don't know that. Unless you culture something and you grow it out in a petri dish, you're not going to know what's there. So we sort of have to assume worst case scenario, I guess. We have to kind of prepare for the worst. And that's best practice strategies. Again, hand washing, we talked about that in the beginning. When you talk about sterile processing, it's all about proper best practice for cleaning and reprocessing our stuff. So where does cleaning always start? Always at the point of use, right? So if we're doing really good point of use treatment, we're following those best practices. We're spraying things down, flushing our lumen to items, wiping things down. When they send it to decontam, and it is your lunch break, maybe you can go eat and because we've done that best practice with point of use, we're going to slow that process. We're going to maybe deter it a little bit, and then you can go have lunch and not worry about it.
Yeah. So is there any kind of because I'm hearing these things and it's terrifying to me, Amy. Is there any kind of stages that are happening at this time? They discussed before with this lunch break here, where we get a turnover or a tray that maybe comes in, you know what, hey, it's time for me to go to lunch. I'm going to go ahead and do that. And then I'll come back and I'll jump right on this. Is there, for our listeners out there and our technicians that are just getting into their role and they're just learning about this, can you dive into a little bit more on that, on these stages of what this biofilm is?
Yeah, sure. So there are actually 4 stages of biofilm formation. numbered 1, 2, 3, and 4, right? So first stage is simply attachment and adhesion, what we call just it's sticking down. That's kind of how I refer to it. So that's the moment that that organic matter, that patient-based soil hits the surface of the device. Doesn't matter what it is. Again, an instrument, stainless steel instrument, it could be an endoscope, rigid scope, anything. But that happens immediately. That attachment and adhesion starts right off the bat. So from there, at stage 2, we call that aggregation. And that's where that microbial growth really begins. So aggregation is that period of time where the microbes multiply, and depending on what they are, could multiply very, very quickly. Rapid growth. This is where we see those microbes take off. The biofilm structure actually starts to form here. That EPS I mentioned earlier is actually starting to be secreted at this point, and the shield is being built. So if you want to think about EPS as kind of like being a superhero, it's got the shield. It's surrounding this microbial colony and protecting it from being removed. So our cleaning processes, detergents, friction, biocidal agents, heat, things like that we're cleaning with, it starts to be kind of like this tug of war. So the shield is protecting and we're cleaning and we're trying to get rid of it. And it's sort of this back and forth, trying to keep all those microbes in place and keep them from being removed. Time-wise, from stage 1 to stage 2 is really not that long. Just a few minutes to maybe an hour, a little over an hour maybe. And then from stage 2, we move into stage 3, which is where that biofilm structure actually matures. Now, this can take hours, sometimes even days, to get to this mature state. But once that biofilm structure is really mature, that EPS matrix is well formed and that shield is solid. And this thing becomes its own little microcolony, if you will, or its own little ecosystem, because those microbes are really smart. They start talking to each other. They literally secrete chemicals out to other microbes and say, hey, come on in here, come in and join our little colony. And, some of the things that's super, super scary to me is that EPS matrix, that dome or that shield, it repels all of our cleaning products. Anything that might actually break through that EPS dome, it's going to get watered down. So think about our chemistries, our detergents and cleaning agents, right? If it gets through that shield, it's going to be diluted. So even if we mix it at the right concentration at the sink, that colony, that microbial situation going on there is so smart, it's going to water down our products and make them less effective. So cleaning is huge. And it's like I said before, point of use. We always start with point of use. And then if we're following those best practices at the sink for manual cleaning, brushing, friction, things like that, that's the best way to kind of prevent it from reaching maturity. After that, after stage 3, that stage 4 is called disbursement. And it, again, can take time for that. It could be many days, up to weeks, actually, before disbursement happens. But what that means is that mature biofilm colony, pieces of it start to break off. Those microbes break off and they migrate. They swim to a different place and they land in a different location. Sometimes on the same device, sometimes on the same instrument, and maybe on the keyboard, maybe on the mouse or something like that. So it's just going to go wherever it wants. And then the whole replication process starts over again. All microscopic. You don't know that it's happening. So what I say to people, let's say you have a really big procedure day on a Friday. You got a doctor comes in, he's going to do 30 cases. Let's say 30 endoscopies. Turning and burning. People just clicking along, trying to get out the door for Friday. Well, if we don't clean properly and we don't really get them, fully taken care of, we put something up for storage, this whole process is going on the whole time. So it's sitting over the weekend. All of these microbes are still growing. It's like you said, they don't take the time off. They don't get to go home and enjoy the weekend. They're sitting on the shelf and they're still growing. By the time you come back Monday, you could actually have a really significant biofilm growth going on and not even know it, not realize that that had happened.
Wow. It's funny, Amy, that you were, the whole time that I was hearing you say this, I kept hearing this old adage. I actually heard my grandmother and say this old adage, this country adage that she always would say, and she loved using it all the time. She's like, "Oh, that's staying in there like a hair in a biscuit." And I just couldn't stop hearing her say that when you were talking to me about this, because you're talking about 5 minutes, right? You get tier 1, right? 10, tier 2, boom. Tier 3, that's when you start to get that 12 hours to 1 day timeline where it starts to build that shield up. And then the crazy thing, right, when you the tier 4, that it starts to replicate, right? Like it starts to, make more and more and more. And I'm sitting there like, wow. What if the old adage was, well, it's not just a hair in a biscuit. The hair in the biscuit keeps making more hairs in the biscuit.
Yeah.
That would be terrifying,
Well,
right?
It is. I mean, and that's why I said in the beginning, it's scary. It's from a science perspective, it's fascinating. How does it do that? How does it know to function that way? But then, yes, from a patient care perspective, holy cow, you want to talk about scary. I mean, I'm not touching anything. I don't want to touch a light switch or anything. So it's nuts how fast that happens.
Yeah, and then the other terrifying thing that you kind of mentioned there, Amy, was that a sterile tray, and it kind of brought me back to when I was a very young technician, and I heard this, and I don't know if you've ever heard this or not, but in sterile processing, you hear a lot of this thing of that you can't sterilize dirt, and it's kind of, it brings back, to the area of that if it has bioburden, right, or if it has something organic, that it can't be sterilized, right? Like if you don't follow the proper process from the beginning, from the point of use cleaning, to the cleaning and decontamination, to the proper soap time, to the proper enzymatic time, to the proper brush, for the proper lumen, to the proper thermal disinfection, to the proper,
That's right.
inspection, right? That you could leave possible bioburden that is going to create this biofilm that is literally going to proliferate after it's sterilized. And I think that's what a lot of technicians don't realize, because they put it in the sterilizer, they put it in the STERAD, or whatever low temperature hydrogen peroxide that they use, right, in their facility. And they go, you know what? That's going to be okay, right? That's going to be safe. And they think that they are doing a good job, right? And they think they're protecting the patients. But if it's not clean, it's not going to be sterile, right?
That's correct. That is correct.
And that terrifying biofilm that you're talking about is going to sit there and over days and weeks, because that's where I think, and I go, well, I'm a good technician, or I'm a good manager, or I'm a good person that's going to make sure our department's doing the right thing. But if we miss something, right, and then we sterilize it, and then it sits on the shelf, and it has that opportunity to grow and proliferate, like you're saying right there, it's going to develop that shield, it's going to develop that protection, and then it's going to start calling its buddies, right? It's going to start calling its friends and say, hey, they missed me in sterile processing. Come and join me, right? And then we're going to cause chaos and problems wherever we need to moving forward, right? Am I kind of getting that right?
That is exactly right. That's a really great way to explain it too. That, I mean, these microbes call out to each other. They literally say, "Come on in," and yes, we're doing our very best. Never once do I ever consider that a sterile processing tech is intentionally not doing something correctly. Everybody's working diligently. Everybody's doing what, they know is the right thing to do. But that's the whole point to this is these microbes are smart. And even if we're doing the right thing the right way, as you said, if something's missed, it can create a problem. And it's not intentional. It's nothing that anybody is, trying to cut corners or anything like that. But it really can be an issue even when we think we're doing things the right way.
Yeah. So I'd really love to kind of dig in to because I think the real life sterile processing technician, that's literally they're flushing and they're brushing and they're following the processes. What kind of complications could arise with these instrumentation and even equipment, right? Like if they're receiving Neptunes that they're wiping down and they're trying to follow the process and they've been doing 1,000 other things at the same time. Can we kind of break down what are the repercussions of those kind of things?
Sure. Yeah. So right off the bat, I think sterile processing, a lot of folks think, oh, well, they don't ever deal with patients. They don't come in contact with patients. They don't really impact the patient. Sterile processing impacts that patient more than anybody else in the perioperative cycle. Because if we don't clean these instruments and items correctly, then these types of things can happen. Okay. Infection. That's really what we're talking about here. We're trying to certainly extend our device life, because there's pitting and staining and things like that. And so, yes, we want to take good care of our equipment. But really, it boils down to pathogenic microbes that cause disease. And there's a lot of data out there that talks about, we all hear about hospital-acquired infections. Back in the day, we called them nosocomial infections. That's an old term, but hospital-acquired surgical site infections. Everybody's heard those terms. 60% of microbial infections that we see in the hospital setting, hospital-acquired infections, are the result of biofilm formation. And 80%, these are real numbers from the National Institutes of Health, about 80% of our chronic wound infections are the direct result of a biofilm development. So you think about in the OR, again, sterile probably doesn't see it too much, but in the OR, we have these patients that are just repeat offenders. They're just coming back for chronic wounds, debridements, over and over and over again. We now know that most of those are the result of a biofilm growth. So, that can happen in a couple of different ways. The big thing that's scary, most of these biofilms that cause problems and disease are the result of like bacteria. You've heard of resistant staph, MRSA, methicillin resistant Staph aureus. So that's a bacteria. Okay. It's resistant to our cleaning processes. We've talked about that already. And that's the point of that EPS matrix. I said earlier that the EPS kind of dilutes our chemicals as it passes through there. It'll dilute our chemistries and our cleaning agents and make them less effective. Well, if a patient has a biofilm infection that we're treating with an antibiotic, because that's what you treat bacterial infections with, that biofilm structure, when that antibiotic kind of works its way through the EPS matrix, it's going to dilute that antibiotic as well. It's going to make it less effective. So we're treating that patient with a dose of medicine that's appropriate, and this biofilm matrix is making that dose less effective. And that's where a lot of our resistant strains of bacteria come from. That's like MRSA. That's kind of where all that comes from. 80% of chronic wounds come from biofilm. That's insane.
Wow.
I know.
Wow. That is, I'm shocked about these numbers here. Associated hospital infections, 60%, chronic infections, 80%, and first of all, that's why we wanted to make sure that we brought this podcast to the masses, because we do know that these are critical numbers, but I am a little shocked on how high these are. I feel like we all should be receiving text messages from from the the government regarding that we make sure that we soak at appropriate intervals, and that the way that I look at this, and correct me if I'm wrong here, it starts with ensuring you have the appropriate amount of dilutions at your sink, right? And how long that you are getting those instrumentation, right? Because we understand, sterile processing is, overworked and underpaid. We understand all of those things, right? But from when we receive those instrumentation, the timeline from where we get to the processing them, the criticalness of ensuring that whatever chemical you're using is properly dosed, and the soak time is appropriate, right, per the IFU and the manufacturer, that we could avoid this 60% and 80% that you're saying here, right, Amy? Am I hearing that right?
We can certainly make an impact in it, for sure. I mean, in some cases, we're not going to be able to stop that biofilm completely, but following those best practices for, care and handling, cleaning, starting at the point of use, doing point of use care correctly, and then just getting it into decon and doing that manual cleaning process as quickly as possible, we can certainly make an impact. We can slow down this growth. And it might just be something like, instead of going from stage 1 all the way to stage 4, where we have that maturity and disbursement, maybe we impact it and we hit it and we kind of slow things down at stage 2. Stages 1 and 2, that matrix is immature. It's a weaker bond. Those microbes are not as stuck. So what we're doing in those best practices can be more effective at those stages. The longer it sits, the stronger it becomes, and the less effective our cleaning strategies are. So that's the key there, is time, just exactly like you mentioned. They call it the golden hour. We talk about the golden hour. We want point of use and no more than 60 minutes until we start manual cleaning. Well, let's be real. That's not realistic in a lot of situations, just not realistic at all. That's why point of use care is so important. But getting it started, getting that manual cleaning process going, again, proper dosing, proper chemistries for whatever it is that you're cleaning, friction, right size brushes, all of those things that you mentioned are vital.
Yeah. So, I'm thinking back to, Dusty 15 years ago, right? And I'm sitting here thinking, man, if Amy had this conversation with me 15 years ago as a technician, and she said to me, Dusty, you can positively affect patients, 60% of them, right, with hospital-associated infections, and you could affect 80% of them with chronic infections by making sure that your OR sprays your instrumentation, right? Which to me does not feel like a large ask. It does not feel like a large ask to say, hey, after you finish your instrumentation, please spray it with an enzymatic pre-clean solution, right? And then I receive it within 60 minutes, right? And then begin my process of a soak, rinse, thermal wash, and dry. I don't feel like that's too much to ask from me from 15 years ago. And I feel like if you told me 60%, 80% of chronic illnesses, I feel like I would don a suit and feel like I was Superman and saving lives left and right. How come we're not doing this? Is there like a, are there areas or things where this biofilm, could kind of hide or locations where it would be difficult for me as a technician to do this that may impact us in these numbers here?
Sure, absolutely. So, any small crevice, any nook, cranny, and a lot of our stuff, y'all know this better than I do probably, that our instrumentation is complex and there are little parts, there are small pieces. So anywhere there's a small area that bioburden can lodge in, remember bioburden has microbes in it, it's going to hide. Those microbes are going to stick down, and the smaller the space, the harder it is to clean anyway, right? Tiny places, hard to clean. You talked about time a minute ago. Even if we do point of use care correctly, if that item still sits dirty for hours, let's say, and we get it down, we start, doing that manual cleaning process, what's going to happen? It's going to be dried. All of that bioburden is going to be dried on the surface of those instruments. It's kind of like going to the family barbecue over the summer and the baked beans sit out for too long, and then you take the pot home and you got that crust around the edge, and it takes forever. You got to soak it and you can't get it off. Bad baked beans. That's what I think of,
Is it sad that I know exactly what you're talking about?
Hey, I'm from the South too, and that's the nature of it, But that's kind of what we're talking about, though. We've got these small spaces in this instrumentation. It sits for a prolonged period of time, so we've got to soak it longer, and we've got to brush it more. So it takes more friction, more elbow grease, right? We're scrubbing it harder. Well, guess what happens if we scrub too hard? Micro gouges. We actually create little crevices in the surface of those stainless steel instruments, which are not good for the life of the instrument by any means, but it's also a conduit for that biofilm to get down inside of. So what we think we're doing that is the right thing, it's actually perpetuating the problem.
Wow. So, Amy, you're really kind of blowing my mind right now. So you're saying that if I'm that technician and I'm sitting here and saying, man, you know what, let's just say robotic instrumentation, because robotics isn't growing exponentially, in this time and age that we deal with here, or orthopedics, right? You're saying that if I'm sitting here and I get something that is grossly contaminated, and God forbid that my OR room has not pre-cleansed it, because we all know as sterile processing technicians that our ORs never forget to spray them down and do the proper cleansing that we need, right? You're saying that I, as a technician, if I take that brush and I kind of put a little more elbow grease in there than what I normally use, I could create micro gouges that then are going to proliferate the biofilm I'm trying to keep from happening. Is that what you're saying right now?
That's true. It sounds crazy, and I hate to say it that way, because we are trying to do best practice, right? The techs are trying to do the right thing. But you think about those instruments, especially stainless steel instrumentation. Stainless steel, we've got surgical grade, but still it can be scratched. We see it all the time. Scratches, gouges, staining, pitting, those things happen. And any place where there's a disruption in the surface integrity, it creates opportunity for bioburden to collect and biofilm to grow. And it becomes this cyclic issue of the longer it sits, the more dried that stuff becomes on the surface, the harder it is to remove, the more we have to scrub. The more we scrub, the more scratches there could be, the more pitting or whatever. So then more bioburden can collect, more microbes, more biofilm, on and on and on. And it's mind-blowing.
Wow. So, kind of what I'm hearing here is that we're kind of in a catch-22 situation here, right? Of where if we receive something that is grossly contaminated, and we're sitting there with our brushes and a lot of facilities don't have started to move away from metal brushes. But I know a lot of facilities that still use metal brushes, right, on the surfaces of stainless steel that could cause these micro gouges that you're talking about here. And we're actually doing more harm than good, right?
Yeah. Yeah. It's very, very important that we're using the right tools. Metal bristles, metal brushes, just definitely not a good idea because they will cause those scratches, those micro gouges. And again, you won't see it, doing the right thing, trying to do it the right way, and end up causing a little bit more trouble than, what we thought or maybe didn't even consider. And again, it's risk to the patient, risk of biofilm, risk of infection, but we're also shortening the life of that instrumentation. Or at minimum, it's going to have to be taken out of service and kind of buffed out, repaired, or whatever the case may be. So then we're down that instrumentation while it's out being fixed. So yeah, we're kind of doing double harm, if you will. Just important to do things the right way.
Wow. So if I'm let's just say, I'm sitting here 15 years ago or so, and I'm this technician. I'm just learning, right? Because, our audience here, we have technicians that are just coming out of school to maybe this is the first time they're hearing about biofilm, right? I mean, depending on, how much they dive into it and how important it is to the facility and all these things. Can you describe to me, because I'm shocked right now, what are some of the best practices and some of the removal of these biofilms and even to prevent it that I can do as a sterile process technician?
Yeah, absolutely. So best practice across the board, ideally we want to prevent altogether. If we can't prevent, we want to remove early in those first two stages. Okay. So always best practice starts at the point of use. So point of use care, whatever that looks like for your facility. It could just be sterile water, wiping things down, keeping items moist during transport, lumen items, flushing them out in between uses, and then it's certainly at the end of the procedure, flushing, wiping down the exterior. And again, it doesn't have to be anything fancy. It can just be sterile water. Definitely don't want to use saline. Saline can lead to pitting, kind of damage the instruments.
Amy, I wanted to jump in here because for probably 1 year, maybe even two, I'm not even going to lie to you right now, probably 2 years, right? My OR consistently used saline, right? Because we understand that when they're in critical cavities and they're in critical portions of the body, right, they can only use saline, right? They can't use sterile water, right? In these critical body cavities, right? I didn't realize as a technician that this was ultimately harming my instruments, right? This saline that I was confused and wondering, how come this continues to rust? How come this continues to pit? How come it continues to be discolored, right? So you're saying here that sterile water is critical in preventing these things from happening, right?
Yeah. Yes. Yeah. So absolutely. We use saline all the time on the field. Not a problem. Okay. Best practice though, from a instrument perspective, when it's exposed to saline in whatever way, when you're done, wipe it, have a rag with sterile water and just wipe it down. Or if it's a lumen, flush it in between uses. And that just sort of, helps to mitigate that saline exposure. But to flush and wipe down at the end of a procedure, to do point of use treatment with saline, you're just exposing that instrument to a substance that's going to, deteriorate that coating, essentially.
Right. So what you're telling me is that not only, because we started off kind of, from the sterile process and perspective, right? Regarding, if I'm using my metal brushes and if I'm in there using extra elbow grease and I could cause more harm than good, right? We're also looking at this from the scrub tech position, from the physician position. We're also looking at it from everyone inside that room, that if I use saline, right, and don't rinse with sterile water afterwards, I could still be causing more harm than good, right? Am I hearing that correctly?
Yes. Yeah. Because it's going to break down that protective coating on our stainless steel instruments. It may not be a significant amount, but it might be just enough, just enough. And if there's already some micro gouges present, that surface integrity is going to be weaker or absent anyway. So that saline can just further potentiate that breakdown. So, yeah.
So, I mean, what I'm hearing is 60%, 80%, right? 60% of a hospital associated infections, 80% of chronic infections. Not only do we want to educate sterile processing technicians, but we want to get this out to the OR as well, right? And we want to empower our technicians to say, hey, I may be a technician, I may be a lead technician that's listening to this podcast right now, and I want to let you know, hey, this saline, not only are you using this saline that could possibly grow biofilm, then the proper process is not only to rinse it with sterile water afterwards, right? We want to educate our SPD technicians. We want to educate our scrub technicians, our physicians, and have that empowerment to be able to speak to our physicians, to be partners, to say, hey, you know what? We could avoid 60% of a hospital associated infections. We could avoid 80% of chronic infections if we do these. This seems simple to me, Amy, and this seems very, very simple, that if we did A, B, and C, we would be 80% more effective. Is that not correct here?
Yeah, I mean, I like the way you put that. That's true. It is very simple, in my opinion. I mean, and I realize time is valuable and procedures don't always go the way we think they're going to. And people are sick and they call out and stuff like that. But, a lot of these steps really are very, very simple to do. And I think you hit the nail on the head, Dusty. This is a team effort. This is a collaborative, not team as in SPD team, not team as in OR team. It's perioperative services team. We're all on the same team. We're all working toward the same goal. Some people touch a patient, some people don't touch a patient, but the job is equally as important because everybody has a piece of this pie to help prevent. That's the root, right? Maintain integrity of our instruments and devices, prevent biofilm formation, and hopefully reduce the number of infections that we see. And everybody has a role in that.
Yeah, absolutely. Absolutely. What's funny is I had, we call them old heads, technicians that had been in the role for, 10 plus years, right? That you're like, you know what? You kind of take everything they say with a little bit of grain of salt. They told me when I very first began in the sterile processing career that we really had to form a partnership with our scrub techs and our physicians because what we did was essentially only, a third, right, that could positively affect our patients. And I feel like that if we had more of these podcasts, more of these people, more of these set downs with subject matter experts like yourself that sat here and broke down real life numbers. Like these are real percentages that you brought forth here, right? 60% of hospital associated infections, 80% of chronic infections. I feel like if you broke it down to very simple terms of, hey, if you were able to utilize point of use care, rinse with sterile water, get to sterile processing within 1 hour, and they were able to begin their process to soak, rinse, wash, thermal disinfect, dry, and begin assembling these trays and sterilize them, we could effectively remove possibly 80% of chronic infections that affect not only the Houston area, but the United States, the whole enchilada, right? That, and I don't have the numbers on that, but I'd love to sit there and bring up, I don't know how we wouldn't unanimously sit there and go, hey, we're going to make this a priority. We're going to make this number one to make sure that this is taken care of. If this was my family, if this was my wife on the table, I would be in there at the table ensuring, hey, doc, please make sure we rinse with sterile water. Please make sure we use enzymatic solution, and I want to make sure my sterile processing technician is in there washing that within the hour of this this procedure. I would be in there with a T-shirt, praising them to say, hey, let's get this done, because I don't want my wife to have one of these life debilitating infections that could change the outcome of their life. Right.
Yeah, absolutely. I mean, and realistically speaking, I know there's lots of challenges. That's ideal state, right? Everything you just lined out, that's ideal state. But there are so many things along that path. Even if we can't do ideal state, there are still plenty of things that we can do, in my opinion, pretty easily, that, yes, can make a huge impact. I mean, I would say probably, gosh, I don't know how many of your listeners right now could probably think, yeah, I know somebody who had a total knee replacement and it got infected. Or, yeah, I know somebody who had abdominal surgery and their incision got infected. A lot of times that's related to biofilm. A lot of times it's, from exactly everything we've been talking about. So yeah, implementing those steps and those strategies along the way could certainly go a long way to help reducing that number of infection.
Well, Amy, I'm just going to throw out to you right now. I mean, according to, our Beyond Clean, our partner Beyond Clean website here, we have 15,000 listeners a week. That would be 9,000 people. 9,000. One of the reasons why we wanted to make sure that this podcast was done and that we were able to bring subject matter experts like yourself into this. That's 9,000 people just in the listeners, right? If we could expand that to every, across the United States, across, even the world, that of the positive outcome of simple things, right? And if you're listening right now as a sterile processing technician, or a scrub tech, or nurse, or a doctor, or a physician, simple things like point of use cleaning, rinsing with sterile water, using your proper 3-sink process, we could prevent thousands upon tens of thousands of hospital-associated infections, chronic illnesses. I don't know how that after listening to this podcast, after listening to Miss Amy, that we could possibly not don the cape, don the suit, the super suit, to sit there and go, I am in a critical area that is not only going to change lives, but is going to change possibly the world, right? Because we have no idea what every single person that's on that table that is going to do. We have the ability to change the world if we do simple processes, right? To make sure that these things happen. I don't know how you could not be encouraged and not be. I don't know how this doesn't make you want to run through a brick wall to be able to do these very simple steps to change the lives of the patients that you're taking care of.
Yeah.
Right? I mean, am I crazy here, Amy?
Not at all. Not at all. I completely agree with you. And I hope, I really do hope from a sterile processing perspective, I want everybody to understand how vital that role is. You know, you don't have to lay hands on a patient to have a major impact in helping a patient be better and preventing infection. I mean, it really does start at the sink. You know, cleaning starts at the point of use, but this work, sterile processing is so vital to this work. And yeah, I mean, you just really hit the nail on the head.
Absolutely. Amy, thank you for your time tonight. I want to thank you. I know we're getting close to time here. I want to thank you so much. I mean, I wish, honestly, 15 years ago, I wish you had a sit down with me and had a couple of smacks to the face to realize, hey, you need to be focusing on these very simple things here, and realizing the importance of what you're doing, right? And realizing the effect that you can have on all of these patients that you do. You know, we deal with small facilities that have 20 to 30 patients, 60 to 80%, right? 100, and some of the largest medical centers have 120 cases a day. You're talking about dealing with 60 patients, possibly, right, that you're positively affecting. I wish we had this opportunity. I wish I had the opportunity to sit down with you when I was a very young sterile processing technician, and had you explain to me the importance, because for me it was all about, I need to get it through as soon as possible, right? So that my boss is impressed with me. And I wish that Amy had sat down with me and said, you know what? Sometimes less is more. Sometimes if you're doing it the right way, it's more positive for your patients. I hope that everybody listening today in the Houston area, I hope everybody listening in the great state of Texas and further beyond, I'm hoping that everybody in the United States and all of the countries, 132 countries that are represented and listening to the Beyond Clean network, is able to take this information that Amy has so greatly been able to dive into, explain to us. I'm hoping that each and every one of you, if we can take just a few things and apply it to our day-to-day work, that these numbers are going to dramatically drop and these patients are going to be positively affected. So, Amy, thank you so much for coming on tonight. Appreciate each and every moment and every minute that we have spent discussing this. Do you have anything that you want to kind of wrapping this up? Anything you want to reach out to anybody talking about? Anything you want to say to kind of wrap this up for us?
Well, I just appreciate the opportunity, Dusty. I mean, I love to teach, but I'm especially passionate about this topic because I do feel like it is kind of the basis of everything that we do. It's why we do what we do, serving patients. And I just appreciate my sterile processing co-workers and friends and, everybody out there that's doing this work. You are valued, you are valuable, and just know that and, stay with it.
I wish I would have heard that 15 years ago, Amy. I really do. I love it. Thank you so much. I think that sterile processing technicians are undervalued every single day. We do the hard work. If I heard this podcast, I feel like I'd be able to run through a brick wall, being able to follow some of the things that you've outlined here and some of the things that seem very simple to me, some that seem very, very accomplishable, that I can not only have my scrub techs be able to do, my physicians be able to do, my fellow sterile processing technicians. But if you're in the Houston area, if you're in the Texas area, if you're in the United States, we want to be able to reach out to you right now and ask you to follow some of these things that we've outlined here. And if you are in the Houston area and the Texas area, please reach out to hsppachapter.com. You can get involved, you can get educated, you can receive some of these things that, some of these subject matter experts like Amy that we have on here tonight, and we can be able to continue to fight dirty. Just like Hank always tells us, we can continue to fight dirty and do the things that we want to do to be able to provide better patient care, better processes, and be able to affect these 60 to 80% of the patients that we deal with every single day. And thank you so much, Amy. We thank you so much for being able to join us tonight. And if you just want to give us a shout out to any of our listeners right now, go ahead for us.
Oh, I don't know about that, but thank you. I appreciate it.
Awesome. Well, thank you so much. And if you want to reach out to us, if you want to get a hold of us, hsppachapter.com. You can always reach out to us. We have our chapter. We have all of our contact information. We have our wonderful sponsors from STERIS, and continue to fight dirty.
All right, if you loved today's conversation, be sure to subscribe and leave us a review, because this fight against bioburden is as big as Texas. If you've got a sterile processing tip, story, or even product that's making it easier for Texas clean freaks to fight dirty, we want to hear about it. Connect with us on social media, anywhere you find Beyond Clean. That's Facebook, LinkedIn, X, and YouTube. Until next time, lasso up those dirty trays and saddle up those sterilizers, because we're about to show the world why everything's cleaner in Texas.